So really, transplant eligibility in systemic light chain amyloidosis has always been kind of a prognostic marker. And what I mean by that is patients who are eligible for transplant generally are fitter, they generally do well with treatments kind of overall. So really kind of baked into the clinical trial, that's 2213, is critical cardiac eligibility markers, so cardiac enzymes, troponin G, troponin I levels, markers of cardiac stress, so things like NT-proBNP, BNP. So these are probably the most critical things that we look at in terms of transplant eligibility. There are a number of other things that are key. So for example, patients who have chronic kidney disease and extensive proteinuria. Well, transplant can be safe for many of those patients, but there gets to a point, for example, when their creatinine clearance drops to less than 30, that even if we offer them a therapy that may essentially eradicate their malignant clone indefinitely, we may end up putting them on dialysis, which really isn't what we want to do. So those are key. There are some other kind of key factors you consider, like resting blood pressure, kind of presence of orthostasis. So again, all those things are really key in terms of getting patients through transplant safe. I would also kind of say the caveat there is that even when we're not transplanting those patients, those are kind of markers that, again, are markers of patients that might not do great with or without transplant-directed therapy. So kind of when patients are newly diagnosed, that's where most of these markers are validated. But certainly after they get initial therapy, a lot of these can be repeated and again, can predict not only eligibility, but can help us with timing. So we still really feel strongly in SWOG and kind of across the amyloid community that probably the best timing of transplant is up front, so initial. We definitely can do transplant when patients relapse, but they're going to probably be 5 to 6 years older. They may have more comorbidities. They may have organ progression. So probably even in today's treatment landscape, if we're going to offer patients high-dose chemotherapy and transplant, it really should be at the initial diagnosis and really early in the patient's disease journey. So.